Hey guys, welcome back to Previa podcast. This is Sarah. And today we know it is Halloween season, spooky, scary. Everybody gets a little uncomfortable sometimes when we bring up the P word, psychiatry. So we are here to kind of break that down with one of our favorites, Dr. Claire Smith. She is the all go to reproductive psychiatrist that's going to break this down. And let me tell you, this is like girlfriend to girlfriend chatting here. So you're going to realize there's no room for scary. So welcome, Claire.
Thank you.
We are so glad to have you. Can you tell our listeners a little bit about yourself and what brought you to this field?
Yes. So, like Sarah said, my name is Claire Smith. I'm originally from East Tennessee. I went far away for college, came back to Tennessee for med school, and I was planning to do something totally different. So for any medical or medical adjacent people out there, planning to do pathology, which was about as opposite from psychiatry as you can get. And then at the very end of my clinical year, in my psychiatry rotation, I stumbled across this field, reproductive psychiatry, that some people call perinatal psych and some people just call women's mental health, and completely changed my trajectory based on that. And went to residency at the Medical University of South Carolina in Charleston, and then did a fellowship there in reproductive psychiatry. And that's where I work now on faculty. And the reason really why this shift happened that really rocked my world and led me to change course is, well, a couple of things. One, I love women and treating women, and I feel really happy in that space. This field is also really nice because a lot of women, most women do get better. And my job is primarily to help normalize what they're going through. And if there's a way to help them feel better faster, that's my ultimate goal. And to have a judgment-free zone to talk about all of their options. And I see myself as sort of providing them with the information that's out there and helping them make the decision that they are most comfortable with.
I love all that. And I say with Claire, she's like a unicorn because reproductive psychiatrist, we wish they were more in the United States. So if you're in larger cities, you would find Claire. And if you're more like the majority of us, you will have psychiatrists. So can you tell just for a minute for our listeners, the difference between a general psychiatrist and you, so they would kind of understand that?
Yes. So reproductive psychiatry, it can vary slightly from program to program, but in general, that means perinatal. So before, during, after pregnancy. And most places, it's about 1 year postpartum is the mark at which they would either transition to a psychiatrist if that was necessary, like a quote, general psychiatrist or a community therapist or whatever else. So we do everything from infertility to any sort of mental health issue under the sun during pregnancy and postpartum, and things like, I have ADHD and I'm wanting to start a family and I take X medication. Is this okay? What do I need to know to help me decide whether I can continue this or not? So basically, before, during, after pregnancy is what we do.
I want to point out to our listeners, there is, people don't talk about this enough, maternal mental health and perinatal mood anxiety disorders, but there is a whole fellowship for physicians to have this because it's such a common occurrence. So I think the fact that we are bringing light to there is reproductive psychiatry that is showing moms that when we experience our mental health issues before, during, after pregnancy, it is validation. It is studied. You are trained to treat this. So there's no shame in this, just like heart attack, strokes, right? Those doctors know what to do. You know what to do for us. So one of the most common things I hear from Previa moms is they are old school in their thoughts a little bit about what an experience seeing you as their doctor is. So real to real talk, what do you want your patients to know, your goal of them coming to see you is?
Yeah, I think the biggest thing I want them to know is that mental health complications are the number one complication of pregnancy. So more than gestational diabetes, more than preeclampsia, more than postpartum hemorrhage, more than postpartum infection, mental health complications are number one over all of that. And so it's very, very normal. And just because it's so common doesn't mean, though, that somebody needs to suffer through it needlessly. I
Right.
think that's first and foremost. I mean, to give any kind of context, South Carolina is not that big of a state. Charleston is not that big of a city. We do serve South Carolina wide due to our virtual services, but we hit an all-time high, I think maybe May or April. We had over 1,000 appointments
Wow.
between the doctors and the therapists. And so this is a highly utilized, highly needed field, and it's not going anywhere. Our numbers are just going up and up and up. And then I think on a more sort of like what I alluded to before is that this field isn't about forcing people to take medications. It's not about making you talk about things you don't want to talk about, or taking your children away, or all these really catastrophic, scary scenarios people get worried about, particularly if they're not used to dealing with mental health services or they've heard some sort of horror story in the past. This field is very research driven, and that research is getting more and more and more sophisticated over time. And so what we do is we present you with the data we have, and we talk about what we think the best option is for you based on not only risk of medication exposure, but the big kicker is risk of exposure of illness. An active illness is also an exposure. And so we've got to weigh those two things. It's not risk versus benefit, it's risk versus risk.
No one ever explained it to me like you just explained it. And listeners know I was very wary when I was suicidal 4 months postpartum to speak up. I just thought it was
Yeah.
me. I had a big negative thought about medicine, right? But
Mm-hmm.
no one ever before to me said, Sarah, you not having help with your depression, you wanted to end your life.
Right.
So no one ever said that to me. So thank you for saying that, because holding depression, anxiety on you and your body
Yes.
without getting help. And we know the data of, because, I present to payers, I present to employers to say, hey, take listen of this, right? Like this. So mental health is physical health. So your outcomes of pregnancies, our preterm births, right? Like the
Yes.
hypertension, preeclampsia. If you even want to talk to a child outcomes for many years with behavioral, or, you
Yep.
see lack of care or more excessive care, it goes both ways.
Mm-hmm.
So I think that moms have to grasp and society has to grasp, right? We have to have this conversation and we have to talk about this early. So say one of your best friends comes to you and says, okay, Claire, I'm getting pregnant.
Yeah.
Let's be real. What should I do for my mental health? What would you tell her? Like, what would you advise her?
Well, it depends. Does she have a history of mental health stuff? Is she taking a medication, for instance?
Let's say she's like, no medication, no mental health history, and she's just hearing it, right? Because let's hit on it. In the news, there's been a lot
Yes.
of tragic stories lately. So the conversation's happening because we've had some worst case outcomes,
Yes.
right?
Yes, absolutely. Yes. So I would probably, there is nothing that she needs to urgently do, some sort of
Right.
magic thing. She can't go to a yoga class and prevent all the bad things from happening. That's
Right.
unrealistic, and that really minimizes the seriousness of what these illnesses are. They're not made up in our heads. They're medical illnesses, like you already said. So what I would suggest would be that if she feels at all like she is not being able to keep up with the things that she normally does, she doesn't have the interest in the things she normally does, if her anxiety starts to feel like multiple times a week, an everyday thing, it starts to feel happening more often than not, jump on it immediately. That's
Yeah.
what I would say. There's nothing special to do, but to be mindful and aware of what can go on in pregnancy and how high risk, particularly the postpartum period is, but pregnancy is as well.
Right. And, we try to have open conversations of risk factors with a lot of
Yeah,
our moms, right? So we know risk factors with anything, like we all, family history, we're talking
right.
about, my personal risk factors. I look back that I didn't know miscarriages, the
Mhm.
infertility, NICU,
Yep.
the lack of support. My husband was in fellowship. We moved away from everything.
Yeah.
So those come into play. And you would know that as her friend, be like, this is you take pregnancy out of this, right? Like that's a
Yes.
hard situation. So I think you
Yes.
got to look at that too, right? Now let's say the same friend, let's switch it up. She's on a medication. She struggled with anxiety her whole life. And
Yes.
here's the thing I hear from all these moms. You probably hear it too, right? It's like, I should stop the medicine. Like there is this conversation. I don't know who started it. I don't know why it
Yeah.
started, but it's like pregnancy, everything we've done before it has to stop, right? Like our bodies have to just be supernatural and we have to deal
Yeah.
with it all because you even like, oh my gosh, should I do this shampoo? Should I get my hair colored? So then if people are thinking like that, you talk about a mental health medication.
Right.
Ooh,
Right. Exactly. So, and I can talk about this for just on and on and on. So
yeah.
please interrupt me and make me change course if need be. But if someone, I do have this conversation repeatedly, probably every week of my job, is that to go way back, our starting point is clinical trial research in this country is essentially men's research. Women
Mhm.
have been excluded as a gender from entire FDA clinical trials for decades. Even now, pregnant women are considered a vulnerable population, the same as minors and the same as prisoners,
Wow.
essentially suggesting that we do not have the ability to weigh all of the risks and options and make informed consent. And so when people talk about the lack of data, that's where I think a lot of the fear comes from, is because it hasn't existed for such a long time. And even things I learned in medical school, I graduated in 2015. Even some of that is, I can see now, is inaccurate or at best, some misinformation from over
Mhm.
time. So I usually set that scene of when we saw it with the COVID vaccine, there was no helpful guidance for OBGYNs, for pediatricians to tell their patients or to guide their patients on whether to get it or not, if they're pregnant, if they're breastfeeding. And so for this specific woman, I would reiterate the whole conversation around risk versus risk. There is no such thing as a non-exposure. Anxiety in pregnancy, like sustained, consistent anxiety, puts you at risk for things like hypertensive disorders, preeclampsia, and so on. Anxiety alone is an independent risk factor for postpartum depression, even if you don't feel depressed in pregnancy. And so when you're looking at exposures, your one exposure of, say, Lexapro or Zoloft or Wellbutrin or whatever you might be on that's providing you stability, that is far less risky when you're thinking about coming off of it and potentially decompensating. So then we're talking about multiple exposures now, which is
Mm.
always the goal, is to, lessen the amount of exposure as possible. Just like we don't want women walking around with high blood pressure, with high blood sugar. We don't want women walking around with high anxiety, high depression. It's the same exact thought process. And so women tend to get this message of, you can take it if you really need it. And we don't send that same message with thyroid medication, with diabetes medication, with anything else. I hear that a lot, even from other psychiatrists. So
Mhm.
nobody's immune to this thought process, but that's the message women tend to get from their personal lives and even from their providers.
Oh my gosh, I love that. I love how you said that because that is, I've never put it two together like that, but I felt like, because I had a medically high risk pregnancy.
Yeah.
And I was like, you do whatever you got to do to me to keep baby and me safe, right?
Mm-hmm.
And no one ever said, now that anxiety, that the high risk pregnancy, I mean, I walked around like a ticking time bomb, clearly. And no one ever said carrying anxiety, Sarah, has its own consequences. Or like they just like I was just forced to accept, like, oh, of course you're gonna be anxious about this. This could end very
Right.
poorly.
Right. Exactly. And I talk a lot about lowercase a anxiety and uppercase A anxiety. We all experience anxiety. Pregnancy is stressful. It is what it is. I'm not saying those women are doing harm to their babies, but when you start to get the uppercase A anxiety, that's when you're considering these additional risks.
Give our listeners just a little quick example of uppercase versus lowercase in pregnancy, because I feel like I was always uppercase.
Yeah. And that's okay. Some people are. And that's when we're like, listen, I'm telling you, I know it makes you, you feel apprehensive about this, but I really think medication is a good idea for you to consider when you've got that uppercase anxiety all the time. And that's what it is. It's something where that you feel like is starting to impact your level of functioning or your ability to function more days than not, consistently elevated, consistently high. If you have a few days that are stressful, or you're just feeling tearful, or you're moving and that's very stressful, that's lowercase a anxiety.
Yeah.
I'm worried about childcare and this new transition for my family, and am I ready? Those are all normal questions that we don't need to pathologize into a disorder. But uppercase A anxiety is consistent, persistent, and impacts your ability to function.
Right. So let's say, so your friend and because we have had this, I've had a lot of moms come to me and they take themselves off, or their OB decides, let's take off this medicine. And then we have really negative outcomes. And then we're trying to rebuild, and we're trying to, it take months to get us back to a spot where we should be. And we see a lot too in the first trimester with that influx of hormones. That's I say that's like a really roller coaster ride for a lot of our moms.
Yeah.
And do you see more so and not? Do you think that's because maybe they were on medicine and they immediately are like, hey, I got to go off? Do you think that makes it worse? Or do you think it's just like, do you think there's any correlation? Because I'm seeing that a lot with just a lot of Previa moms. Is this that first trimester?
Yeah, I'm sure there's got to be. It's that very beginning, but then also in between, the in between time where if you are sort of unfortunate enough, but also, and some people are really reassured by feeling nauseous, when you're in between the morning sickness, which we all know is not restricted to the morning, but if you are experiencing nausea or vomiting, that then gets better, but before you're showing, before you can feel kicking, that is also an incredibly stressful time period where you just feel like something's going wrong. I don't have the feedback that's telling me I'm still pregnant. Everything's going, quote, normally. But yes, the beginning as well, certainly. And I think that a lot of that can be when the women find out they're pregnant, they stop their medication because they want to, or because someone told them to. And then the wheels kind of come off shortly thereafter, or can.
Absolutely. Both pregnancies, you nailed it. You described me. I'd feel nauseous and I'd be like, okay, that's still good. Right. Yeah. And then, it was really hard when you can't feel the baby. Yeah. And I don't think people talk about it. And the anatomy scans around that time. Right. So that's a high stress. So what can moms do so they're listening and we're hearing this mom and she's on medication, she's pregnant. And maybe her OB is not receptive of her knowing both options. What could we help empower her to gain more information, ideally find you, say, right, what can she do? Because I feel like moms are always like, well, I tried, but no one heard me, or I couldn't figure it out. And they fall in this like care gap.
Yeah. And I'm not sure if this has been something discussed on this podcast before, but PSI, Postpartum Support International, is an excellent resource that it's a website you can go to and has just abundant resources, even groups of their own, information. Mothertobaby.com is really helpful in just like a quick snapshot, easy to read fact sheet about different medications in both pregnancy and lactation and fertility. It takes the kind of difficult to understand, dry, academic, researchy language and distills it down into easily understandable guidance on or safety profiles of medications in pregnancy. So probably those two things are where I would start. And Postpartum Support International can also connect you if there is anybody in your area, even if it's not in your city. Now with post-COVID, virtual is pretty much an option for most practices.
Yeah. And I will say, I always tell people, it's okay if your provider does not align with you to seek another provider. I think there's a hard line. Sometimes different providers choose with their knowledge and comfort level of mental health medications during
Yeah.
pregnancy and postpartum?
Yes. Yes. We are, I know we were discussing this early, but we're at a kind of a transition point, I think, where the need is so great and it can't really be ignored anymore. And so non-psychiatric, non-reproductive psychiatric providers are realizing I've got to get comfortable with this and understand what the algorithms are. And we're at a sort of a funny point where some people are really diving headfirst into that. Some people are a little resistant. It's some confusion, some misinformation. I think we're on the right trajectory for non-mental health providers to be comfortable in that space. We're just not quite there yet. And that can cause some even more anxiety.
Yeah. I will say, there is at Postpartum Support International, if you love your OB, or, we have maternity deserts, right? This might be the only
Yes.
OB for X amount of miles for you.
Yeah.
And you have this question about the medication, you could always refer your OB. Postpartum Support International has a reproductive psychiatric line. They can call in, and you
Yes.
could even say, can I be a part of this conversation and hear from a reproductive psychiatrist like Claire? Let's talk through this. And now you're going to have with this podcast some terminology and some language that you can bring to advocate
Yeah.
for yourself.
100%. No one's going to advocate for us except for ourselves. That's
Mhm.
an unfortunate lesson I think we've all learned as women and as patients at some point in our lives, particularly around pregnancy and, I mean, not just mental health symptoms, but physical symptoms, pain and things like that, were frequently dismissed and ignored. So, I mean, that's huge. You've got to advocate for yourself because you cannot be sure that anybody else will, unfortunately.
No, I think that's so true. Now, so when do most people come to see you in the pregnancy journey? Where would you think more so or not, they're going to come in?
Yes. And so I exist sort of in the OBGYN sphere. Our clinic does. We have a whole division at MUSC with different doctors and therapists. And so there's a very easy way to come in internally. But then we also have like this line you're talking about with PSI where you can call in as a provider or as a patient. We have that for our state. So anybody across the state, patient or provider, can call. They don't need a referral. They don't need to be at MUSC, anything like that, and be triaged by one of our social workers and scheduled or whatever they may need. But as far as when I most commonly see women, it really varies. Some women, it's early. Some are, I was on X medication, I stopped, I'm in my second trimester, I am struggling, I need some help. And some women have no mental health history whatsoever. They've had their first baby and they've realized that something is really not going well. And they've talked to their OB or pediatrician or just themselves or family members. And that's how they come in. So it really varies widely. We see women
Yeah.
who come in before they're pregnant, and we see women who come at 10 months postpartum.
Now, we haven't touched this yet. So the people who are going through IVF, or they're going through like trying to get pregnant, that is
Yeah.
a very mentally taxing time.
Yes. Yes.
Now,
Incredibly so.
so when they come to you there, would you expect their relationship to maintain with you guys through the pregnancy and postpartum if they kind of established early on?
Yes, I would. I mean, it can
Okay.
always be case by case, and it depends also what the woman feels like she needs and what
Yeah.
if she's good with just a check-in or just kind of establishing, and then she can come back if and when she is pregnant, or if and when things get worse or whatever might be. But yeah, that's included in our umbrella of what we're doing. I wouldn't say it's a huge amount of our patient population because MUSC does not have an REI, a
Okay.
reproductive, or like an infertility program or fellowship. But I personally have probably 2 or 3 patients that fit that category.
Yeah. We first got pregnant, then we had a loss, and then we struggled to get pregnant again.
Yeah.
And I think that story's a lot with a lot of people is
Yes.
that time and what you're carrying. I always tell people you get baggage that you bring into pregnancy.
Yeah.
Like we're carrying our anxiety, or I'm carrying like some underlying conditions in pregnancy. You throw those hormones and it gets
Yeah.
really kind of messy. So let's talk a little bit about the mom who everything was great during pregnancy, right? She was like trucking along,
Yeah.
postpartum comes.
Yeah.
And okay, the difference between baby blues and postpartum, we'll just talk about that for a second in case our
Okay.
listeners have never had this explained to
Yeah.
them. So, because I
Okay.
think some people get that really confused, right? They're like,
Yeah.
people get uncomfortable during both times. So let's just
Yes.
make it very clear what baby blues is versus postpartum depression.
Yes. And this does happen a lot. And I think that there is, I mean, I would rather people get referred because they're struggling at 1 week or 10 days or 2 weeks postpartum rather than wait and wait and wait. And then they've realized, well, nope, it hasn't gotten any better. Now we'll refer. So in med school, it's always stuck with me that one of our endocrinology professors said if like the female hormonal system and neurotransmitters and all of those things, hormones tends to be this like slang derogatory term almost like hormone,
Yeah.
she's hormonal or it's the
Yeah.
hormones. And in reality, it's an incredibly complex system for women, even much more so than men. And our professor was like, our men would never survive
Mm.
pregnancy and postpartum if they had the same hormone shifts that we did. And I firmly believe that. But those shifts are going to create mood instability, tearfulness, feeling emotional, feeling depressed. I mean, you will feel exactly like what major depressive disorder feels like. If you're a new time mom or a first time mom, there's a lot of anxiety about keeping this little thing alive, you know, obsessively watching the monitor, watching them breathe, things like that, that if persistent, yes, we might be talking about something that's in the disordered family, but going to be pretty normal in your first couple of weeks. And so when I see someone that early on, unless it's something that includes suicidality, certainly, or something that feels just really severe, or they have a long history of depression. And so I know that they're going to be high risk for it anyways. I'm generally avoiding starting a medication until the first couple weeks in. And so we can see where that trajectory is going. Of course, if mom wants to go ahead and get started on one, I'm never going to say no. But that's
Mhm.
generally a good time frame is around a month-ish. Patients don't follow textbooks, you know, so I just want to reiterate that.
Right.
But if around 4 weeks or so, it's not that you are feeling fine, it's that you start to feel like you're not treading water quite so much, or it doesn't feel like an everyday, all day oppressive type of mood or anxiety symptoms that you're having. You're just feeling like, okay, I'm getting into groove of it. It's still exhausting. I'm feeling still emotional. It's difficult, but I'm getting the hang of it. And I feel like I'm doing a little bit better than I was 1 or 2 weeks out. That's what baby blues looks like.
Yeah.
Whereas postpartum depression is not getting better. It's probably getting worse and or is going to be more severe symptoms.
Yeah. So I always say, and to our moms, I'm like, it will, baby blues go away. And, the research says 80, 90%. I'm like 100%. A hundred
Yeah.
percent of my friends and me have like had
Yeah.
baby blues. Like
Yeah.
everybody's going to have it. And for me, it hit usually like 3, 4 days postpartum.
Mm-hmm.
It kind of hit. And then day 7 be like, oh my gosh,
Yeah.
and I don't know if that had any correlation with like my milk really coming into or what
Yeah.
happens around that. But
Yeah.
I do want to, we'll talk on this in a second, but weaning and milk
Yeah.
that comes into play. No one talks about
Yeah.
this either. So that's a
No,
huge thing.
no,
But
no.
baby blues goes away. So you're not
Yes.
going to, I tell people though, you have to ride that train. It's very unfortunate. You have to get
Yes.
on, get to your destination to see if it's going to get better or worse.
Yeah. There is some of that, unfortunately. You can sort of think about it in terms of if, say, you were in a car accident, you're probably going to be a little scared or anxious around driving for a little while. You might have some memories that are bothering you about it for a little while. If that's still going on, or you feel like you can't drive, or you feel like you're just having nightmares or you're avoiding things, sort of the difference between acute stress symptoms and PTSD. That is kind of a similar mirroring for blues and postpartum depression. You expect these things after such a massive physical transition, hormonal transition, life transition. You've got to give yourself a bit of a break in terms of the expectations you have on yourself and how you're going to be interacting with the world around you. But yeah, exactly. Some of it is just waiting and watching.
Yeah. Now, what's interesting is we've had a couple moms recently who they've stopped breastfeeding, like I mentioned earlier,
Yeah.
And one specifically said to me, I thought I was good. I didn't think I was going to get
Yeah.
depression. I was not anxious. I
Yeah.
weaned,
Yeah.
and holy moly, this hit hard.
Yeah. Yes. I see that. And I see the opposite too. I see women who are really struggling. And it also is layered with the fact that typically breastfeeding is not going smoothly for them. They're struggling with latch, they're struggling with supply. They feel like a human milk machine, and it's just not working for them. And they're feeling a lot of shame and guilt around weaning. And then they do, and they feel a lot better. But you're exactly right. Some women are doing okay. They wean, and it's like, bam, where did that come from? Yeah,
Yeah.
see it all the time.
And I don't feel like people are, we're talking, hey, this period of time, postpartum depression, postpartum anxiety, if you've had a traumatic birth, these may be the things,
Yeah.
but no one's telling you the weaning
Mm-mm.
part. And
Yeah.
I think there's a huge, well, we do know it's biodirectional if you're breastfeeding and depression, right? So it can, if you're struggling, you're already assuming like, I'm not a good mom. Why can't I do this? Everybody seems just to be able to whoop, put the baby there and feeds and moves on. What am I doing wrong?
Yeah.
So
Yep.
my second child, I decided from my own mental health, I needed to wean and to
Yes.
go to formula.
Yes.
So I think that if you're a mom listening on this, your mental health is more important than
Yes.
how your child is fed. People may
Yes.
feel very strongly against that statement I just said, but I truly believe healthy mom, healthy baby.
100%. I have that conversation a lot with women, and a lot of it seems like they were just sort of waiting for anyone to say, have you considered weaning? And just like the relief that they feel even being able to vocalize that and work through
Yeah.
the shame and the guilt around it can be very helpful. And sometimes, they're not ready and they decide again in another couple of weeks or couple months, but they know that the option's on the table, and it doesn't mean they're a bad mom.
No, and that's just I always say how you delivered your child to this world and how you feed your child.
Yeah.
Okay. No one should judge you as a mom based on that. And you shouldn't judge
Yeah.
yourself. I want to
100%.
touch on with you traumatic births. That's been kind of a
Yes.
lot that's coming. I think it's now there's some good Instagram accounts that we're kind of talking about it, right? I have had two traumatic births, and no one ever had shared previously with me like their experience or how that could affect my mental health, how that would be my risk factors. I think that it goes back to like what you were saying in the beginning. We have not been allowed to be in this conversation about
Mhm.
anything for so long. So no one's looking at the mom and her birth experience and saying that was really scary. That was traumatizing. You had no
Yeah.
control. That's not okay what happened to you and this after effects. So, do you have any patients that you've kind of had to work through like their trauma and needed
Oh,
you?
yes. Yes, 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 absolutely. We see a lot of trauma in clinic, whether it's pregnancy loss or whether it's a traumatic labor delivery experience, and whether that is literal physical trauma and an urgent or emergent C-section or hemorrhage or whatever, or if it's simply just an unplanned C-section, that can create a whole lot of trauma that I think as doctors, we see C-sections happen all the time. OBGYNs see it happen all the time. And so you can understand how people get a little desensitized to it. But yes, just a simple question of what was your delivery like? Tell me about it.
Yes.
You would be amazed at what people experienced that you might not know just from looking at the chart, and how they're feeling about it and how they're still reeling from it and having some residual issues and want to talk it out. Oh, yeah.
Yeah. I still get off around my children's birthdays. And
Yeah.
one just
Hmm.
turned 2 and one's me 5 in August. So I think, and my husband's a physician, I'm a nurse. So like he does a whole different line of work. And he's even said it, he'll describe something that happened to him during that day, procedures, surgeries, other stuff. And
Yeah.
I'm like thinking, I'm like, oh my gosh. And to him, he cares very much. This is not whatever, but he's very like
Yep.
compartmentalized with it, right? And I
Yep.
try to tell this to moms. I'm like, these people are seeing it every day. This is you. This happened to you. Your
Yeah.
life, your child is a healthcare system kind of failure it set us all up for, right?
Yep. Yep.
And
100%.
they're
100%.
trying to save your life or your child's life, right? And sometimes
Yeah.
there's not a conversation piece of like, this is what's going to happen or not. So we've had a lot, I think, and like you said, trauma is whatever's trauma to you, right? So
Yes,
it could
yes,
be my circumstances where we had like one of the fastest C-sections for a hot minute, or it's she did not want that and this happened to her.
yes. Oh, yes, 100%. And it can be just, I had an interaction with one of the providers taking care of me in the hospital that really made me feel invalidated or uncomfortable or, even unsafe. And that can cause a lot to surface, particularly if you have a history of trauma in the first place. It can just add layer after layer.
I think it goes back to that. I think these moms have been trying to say something's wrong or that's not what they want,
Yeah.
and no one
Yeah.
listens.
Yeah. Yes. And there is a difference between having a birth plan and thinking it has to go that way, and any deviance from that means that I was a failure or it didn't go the way I wanted. And sometimes, you can have a birth plan, but best to be a little flexible.
Yeah,
That's different than what we're talking about here.
totally. Now, where do you hope this field that I know you're working
Yeah.
hard in research, where do you
Yeah.
hope this is going to go? So if I talk to you in 2 years and I'm like, Claire,
Hmm.
what's
Hmm.
changed? What do you hope? What do you see?
A few things. I will say that I see, so as part of my job at the hospital, I also interview any prospective general psychiatry residents who have expressed an interest in this field to give them just the details about what we offer, so on. And I will say it's a growing field and the interest is really exponentially growing. That's reassuring because I think, number one, we need more of us around. And honestly, probably one of our biggest goals is that reproductive psychiatrists can be there when you need them for things that are not responding to your first line treatments, for things that are really complicated, for stuff that you really don't expect a non-mental health provider or a non-specialist to handle, but that primary care doctors, OBGYNs, midwives, that they can become more comfortable, like we're saying, in treating all this population. So there aren't these deserts where people don't know what to do and there's nowhere to send them. I think that is my ultimate goal, is that we don't have 1,200 appointments a month because other physicians and providers feel comfortable. They're not afraid of pregnant women, or women who have
Yeah.
had babies in the last year.
It's exactly what you said. I've had a friend, she's a different part of the state, and she said to me, I think they were afraid when I got pregnant because of my past history.
Yeah.
And she was like, it's not something I didn't already know. And the woman knows, right? It's like, we
Yes.
know what our history is. But I think even feeling like your provider's uncomfortable with what you're bringing into it.
Oh, Sarah, we have, I mean, it is a regular occurrence where I see a new patient who was just cold turkey dropped by their psychiatrist or their primary care doctor, whoever else. I don't mean to harp on these. This is just what
Yeah.
I see consistently. Just
Yeah.
unfortunately happens because they got pregnant and that's it. Wouldn't give them
Yeah.
any more refills. Not, thankfully, we have this resource in our state, but that happens everywhere.
I
Just
mean,
because they get pregnant, all of a
yeah.
sudden it's like, you're not a human being anymore. I don't know what to do with you.
No, I felt that. And, I searched, when I was suicidal, I called around to several places and
Yeah.
they said, wait, you're postpartum? Wait. And I'm like, "Ah."
Mm-hmm.
So like that challenge, I don't think people talk about it enough. And like
Mm-mm.
it's out there. So you have
Mm-hmm.
to know we do have the odds stacked against us. But again, we go back to advocating for ourselves, right? Postpartum
Yes.
Support
Yes.
International. If you are in the state of South Carolina, you are a lucky duck because you have your guys' program there. And right, you can tell your provider, no, you call this hotline. We're going to talk about this, right? I know other states are trying to do that, but you have to know like this is our most vulnerable period of a woman's life for a mental health condition is the perinatal
Yes.
period.
Yes.
Yet no one is backing her and supporting her without her trying to say, hey, I shouldn't feel this way. Like I don't
Yes.
have to just take it.
Yes. And
And
this is a very sort of hard and serious topic, but it's the reality. Suicide is the number one cause of death within the first year postpartum in our country. And the fact that Our screening is so poor. Our resources are so poor. It's a disgrace, really.
Yeah.
And I don't think, though, a lot of people, much less doctors, are aware truly of that statistic.
They're not. And I've actually just trying to advocate and get more resources to moms
Yeah.
have said that. And they look at me and they go, is that right? And I'm like,
They don't
yes,
believe
it's
you. Yeah.
right.
Yeah. They don't
They
believe you.
don't.
Yeah.
They don't. And I'll say, post COVID now, and their numbers we're hearing 1 in 3 postpartum depression, postpartum anxiety from moms. And they're like, I thought it was traditionally 1 in 5, 1 in 8. And I'm like, well, what we've went through the past couple of years,
Yes.
okay? We're all having a baseline of anxiety after COVID.
Right.
So why would that not be worse with hormones? And I think what's important too is, people think, okay, well, postpartum depression, anxiety, that can only happen in the beginning
Mhm.
of postpartum. Or they don't even like talk about like depressive symptoms, anxiety symptoms start during pregnancy, right? So like we are just but our moms, the highest rate, correct me if I'm wrong, of suicide is between 9 to 12 months postpartum for that delay kind of later. His postpartum depression does not get better. That's why something without treatment and resources, it gets worse. So they also, I've had people say to me, I was really confused when my mom came back asking for something at 6 months postpartum. I didn't know why when her baby turned 1, she said, this was the worst year of her life and she was
Yeah.
suicidal. I'm like,
Yeah.
they just don't
Yes.
talk about it. They don't know.
No. The highest risk for overdose is 6 to 12 months postpartum. It's, I mean, it's multiple things, but your protective factors can be a little clearer for you when you have a teeny tiny little infant and you're still just trying to get through each day. When you are, for some women, back at work, like you're out of your postpartum really small bubble, like the world keeps turning, you're expected to turn back with it. That's where a lot of that comes from, even though you'd expect it to be immediately postpartum, which sometimes it is. But that transition point of when you're kind of getting back into life can be very difficult.
Yeah. And I've heard that a lot is I'm now back to work
Yeah,
and the village of our hope in the beginning has left.
has gone.
It's gone and you're here and
Yeah,
you just attribute it to like, oh, well, when the baby sleeps, I'll feel better. Right. When the baby's not
yeah,
teething, this will go away. Right. I don't know. You just put in your head all these like little steps that's going to make it go away that it just doesn't. And
yeah,
again, I think too, no one's telling her it's how long it can last. So then she's dismissive of her own feelings. And then she starts looking and say, it's just a me thing. It's not a mental health thing.
right. Exactly. I do not remember the percentage off the top of my head. I haven't looked at it in a little while, but there is a non-small percentage, not a huge percentage, but not a teeny percentage where postpartum depression symptoms persist at 2 years, even if you haven't gotten them treated or addressed in some way. So I see women who are coming to me in their second pregnancy, third pregnancy, and they're like, to be honest, I felt this way after I delivered with my first, and yeah, it might have plateaued a little bit, but I never really felt any better. I think I've essentially been depressed since then. That makes me really, really sad, but it's not uncommon.
I was going to say, because most people tend to get pregnant a couple of years after their child. They kind of you're like, well, I'm in these childbearing ages. Let's just kind of get through these trench years. And I've heard that a lot from our moms, our previous moms, is, gosh, I wish I would have had you guys in the beginning. I didn't know. There was no name. So let's just real quick hit on this. So I was very scared to get pregnant again after my experience of postpartum depression. And I did not have a you or someone with your knowledge to go to say, what? Okay, to the mom who she suffered, right? She had postpartum depression, postpartum anxiety, hey, even postpartum psychoses, right? Like she had something.
Mhm.
She wants to get pregnant again. She wants more kids. What would you suggest to kind of is it finding a great provider like yourself? Is it having open, honest conversations? What can she, because that's a hard decision, right? Because I was like,
Yeah,
do I want to get to that point again? Like I
right.
have a child now. Like, what's if I feel this way?
Yeah. I think it's a really valid question. And I think you're right. It's not one size fits all. Same thing for if you had a really complicated pregnancy, strictly medically speaking, or had really serious issues with nausea and vomiting the whole time, you're going to think hard about doing it again. And that's really normal, whether it's mental health or strictly physical health. But I would say ideally, in a perfect world, you have a provider, even a specialist like what we do, that you can at least establish with, make contact with, do that intake appointment. You can check in once a trimester if things are going really well. Just you have that connection there, and they're there right away if you need it or if things start to decline.
Yeah. Have that
I,
plan.
yeah, have a plan in place. I think that's exactly right. Have a plan in place and know, not just for you, but for your support people, whether that's friends, whether that's family, whether that's a spouse. This is what happens. We've seen it before. This is what happens when I start to feel worse or my depression episode starts. And even if I can't recognize it, somebody else can, and we can address this quickly.
That is the conversation that actually me and Bill had. Was I hit it very well from him, which, I mean, he was in fellowship. So
Right.
it was easy for him to hide things when you're working insane hours, but it was like, if you notice me fixating on this, if you notice I stop going to this, which I love to do, if you notice that you're watching him, but I'm not sleeping because I'm fixed, then
Yep.
you had to have these uncomfortable conversations of, it's not your fault that you didn't recognize it. It's not my fault I didn't speak it, right? Like now it's a us conversation, right?
Yes, I totally agree. I think that's invaluable. And I think that unfortunately, what happens sometimes is the motivating factor for treatment is that there hasn't been a discussion. And so a spouse or a parent or someone is like, you're being really moody. You're being
Mhm.
really snappy at all of us. Like, something's wrong with you. You have bipolar disorder, using
Yeah.
these terms just like wildly and accurately. And then they come to us and they say, well, they told me I was doing X, Y, and Z. And I guess I am raising my voice more at my kids, and I don't want to be doing that. And if you are aware of this beforehand and you know the names for it, you can put labels on it, and you know that it's nothing uncommon or there's nothing wrong with you, that can save a lot of distress and can get you to care faster.
Name it to tame it. We say that a lot. Like,
Yeah.
I felt bad. I was like, okay, I know this was, I mean, I had postpartum rage with my second and very untalked about, but just to say, hey, this is what I'm experiencing versus, gosh, I've turned into an angry, like snappy
Yes.
person, right?
Yeah.
That helped me a lot. But I want to have you back because this conversation is, it's so much should be limited to a time frame, but
Yes.
because we have to be the voice that moms hear, because there's so many contradicting, negative,
Yes.
shameful, just suck it up, gaslighting, whatever you want to call it, that they're hearing, that they have to find this conversation to take into their pregnancy, postpartum journeys.
Yes. I agree. Totally happy to be back. You know how many times I've heard postpartum depression didn't exist when I was a mom, when
Uh,
I was having kids. And I'm like, okay, that's not true. It's not a 21st century illness. But yeah, there's a lot of that out there. And I think the discussion is happening more and more. And even on social media, like you mentioned at the beginning, in terms of, Instagram can be a little worrisome, the sort of Instagram therapists and the Instagram experts. But there is a lot of value in that shared community and shared experience. But podcasts and books, and I think it's coming a long way. We just still have a long way to go.
we have the conversations continuing. We always ask our guests this. So, what would you tell, a mom to be the advice that like you wish like she could know? And, we've heard everything from freeze your eggs early to put your oxygen mask on first to whatever. Just you see these moms, this is your passion, just that word of wisdom. And it doesn't even have to be like doctor wisdom, right? It can just be
Right,
like female to
right.
female. Yeah. What would you
I
say?
think in terms of non-doctor and non-medical advice and the things we've already talked about in terms of advocating for yourself and being aware and making a plan, it's probably that you are not meant to do it alone. And the reason why there's this cliched saying of it takes a village is because it literally does. And human history would show that. But for some reason, we're in this portion of human history where we think that moms need to be able to do it all on their own. And you will need help. And you also need to ask for help.
Yeah.
Not only that, but you need to accept help. And so if you don't accept help, at some point, people will stop offering help.
Yeah.
And that can get really scary really quickly. And that's probably my biggest piece of advice.
I love that. Where were you before? I mean, I'm from East Tennessee too. So I like was Claire to tell me that when I was pregnant. I needed that. I needed that. So moms, hold true to that. And I don't care how old your kids are right now. Like that is,
Exactly.
oh, okay. Well, this has been, we took the scary out of it. You
Yep.
know, this is, I know this conversation, that's what you got to do is you got to talk through this the uncomfortable. And we're going to keep having this conversation. I'm not going to let Claire get too far away from our listeners so we can share her knowledge. But Claire, it's an honor. Thank you for being on with us.
Thank you so much for having me. Happy to be here.
All right. Okay, guys, till next time.
Maternal mental health is as important as physical health. The Previa Alliance podcast was created for and by moms dealing with postpartum depression in all its variables, like anxiety, anger, and even apathy. Hosted by CEO, founder Sarah Parkhurst and licensed clinical social worker Whitney Gay, each episode focuses on specific issues relevant to pregnancy and postpartum. Join us and hear how other moms have overcome mental health challenges, as well as access tips and suggestions on dealing with your own challenges as moms. You can also browse our podcast library and listen to previous episodes at any time. Please know you're not alone on this journey. We're here to help.